So welcome. I assume all of you are either from the East Coast or just pathological morning people, so welcome. So I'm Dr. Melissa Rahill. I'm an associate professor of neurology at the University at Buffalo Jacobs School of Medicine, SUNY. Go Bills. And with me today, I have my dear friends, Dr. Rebecca Birch. She's the director of Headache Medicine Fellowship Program, assistant professor of neurology, and the Division of Headache Medicine chief at University of Vermont, Larner School of Medicine in Burlington, Vermont. And I have Dr. Dina Kuravilla, neurology and headache medicine medical director at Westport Headache Institute in Westport, Connecticut. So I myself have no relevant financial disclosures. And here are the disclosures of my co-speakers, Dr. Birch and Dr. Kuravilla. Okay, so as people trickle in, I'll review the goals and objectives of our session. So I know all of you are seasoned practitioners at this point, but we'd like to review some helpful pearls about how to take a really good headache history that you may have overlooked. We'll review approach to using acute and preventive migraine therapies. We'll highlight new acute and preventive therapies, and we'll explain the importance of shared decision-making when initiating treatment. I ran into one of our dear colleagues from Greece who we trained with in residency, and he said, I see a lot of headache medicine, but all those new drugs, man. So presumably, some of you are here for an update on those, so we will be discussing how to incorporate those into your practice. Okay, so let's start with case number 1. We'll be going through 6 cases today, and we'll be swapping through the 3 of us, and we'll hopefully keep it interactive, and then we'll leave lots of time at the end for questions. Okay, so Erica is a 38-year-old high school teacher with severe headaches. She recalls that she did have headaches in college. She would sometimes have to miss class for them, especially prior to getting her period. Recently, her pain is worse with 1 severe attack per week, and the over-the-counter medications she's always relied on just aren't helping anymore. She describes her pain as across the front of her head. It starts dull and builds to throbbing, and she gets a little bit nauseated when they get to their most severe point. Okay, so we all know what the diagnosis is, right? This is a neurology conference. But I'd like to ask my co-speakers, what are some of your pearls for eliciting an accurate headache history? And then what would you say this person's diagnosis is?
So I think that as neurology colleagues, we're so primed to look for red flags in the history. As a part of the history and the physical exam, we're always looking for, does this person potentially have temporal arteritis or spontaneous intracranial hypotension? I'm here to tell you that, at least in my experience, in my practice, the vast majority of women specifically and people that I see with headache have migraine. Especially women during the childbearing years and perimenopausal period, right? So there are green flags or comfort signs that we can look for. If someone's had a headache since childhood, they've had headaches on and off since childhood, if they have a family history of headache, if it's hormonally related, if it's around menstruation, or if they're having other signs of perimenopause, then those are comfort signs that can make us feel better about the diagnosis of migraine while we still rule out some of those red flags.
So a lot of the time we have a checklist of things that we want to get through and ask, but often I find it really helpful to simply ask patients to tell me their story. Start at the beginning and tell me about your headaches over the course of your life. And that can really give you a sense of how things have changed or not changed, how they've evolved, and often patients will tell you all of the things that you need to know as they are talking. And most of the time, what we see is primary headache, as you said, and most of what we see in our practice is migraine, because migraine is by definition more severe and more disabling than a lot of other headache types. So I would encourage you to think migraine as opposed to things like tension-type headache.
I totally agree, especially that last point. If you just went through and said, okay, are you sensitive to light, sound, smells, nausea, you'd get that it's a migrainous headache, but you might miss the fact that well, I just woke up one day with a headache that never went away versus it kind of, gradually increased in frequency and intensity. So listen to the story, super important. So migraine is real, migraine is common, and migraine is disabling. A lot of the patients that I see in my practice they say something is wrong. We need to figure this out. We need to get to the root cause. I know there's got to be a test or a scan or something to validate the amount of suffering that I am going through. And it's important to provide that validation, but it's not always a structural underlying etiology. Sometimes it's more of a software problem than a hardware problem, as I say. Migraine is not just a headache. It's a neurological, sensory, autonomic, vestibular, cognitive, and even you have GI symptoms with it too. It's a chronic neurologic disease, and I think I heard one of our colleagues say once that we have these sensory superpowers. So I myself have episodic migraine. And so, yeah, we are more sensitive to light, sound, smells, internal stimuli, vestibular stimuli. We have sort of different sensory thresholds. It's incredibly common. 1 in 10 children have migraine. 1 billion people in the world have migraine, and over 47 million Americans have migraine. 7% have chronic migraine. It's disabling, so it's the leading cause of years lived with disability in people under the age of 50 worldwide. And the peak prevalence during the working years, 25 to 55, that means it really tremendously impacts productivity. People are trying to have families, get ahead in their jobs. It's incredibly disabling. It's important to acknowledge that. So here are the diagnostic criteria for the International Classification of Headache Disorders. You all know this, but I will talk about a couple of things that I think are worth highlighting here. So particularly when you look at the 2 out of 4 criteria on the left, it says it's typically unilateral. It can absolutely be bilateral. It tends to pick a side when it's at its worst. It can be pulsating or throbbing. Again, tends to be at the worst point. Moderate or severe intensity. I think that is a really important point, and Dr. Birch touched on this a little bit, but in comparison to tension type headache is a mild to moderate intensity primary headache disorder. So this is super important. If you meet someone who has intermittent severe headache, and presuming they have no other, red flags, the diagnosis is migraine until proven otherwise. Okay? If they're saying that they have severe headache, it's probably not tension headache, because tension headache is a mild to moderate headache syndrome. And that's why a lot of people go under-recognized and underdiagnosed and undiagnosed. Aggravation by or causing avoidance of routine physical activity. This to me means, when you have a headache, when it's at the worst point, you just don't feel like going to the gym after work. You don't feel like going to the grocery store. You don't want to finish your notes. You just want to get home. You tend to want to withdraw from things. And a lot of people say, well, I have a high pain tolerance. I push through. I do what I have to do. But that's not what you're asking diagnostically. You're asking, what is your body compelling you to do? So when your headache is at its worst, is your body telling you to slow down a little bit and withdraw from things a little bit? And if it is, then I would say that that's migrainous. You have to have at least one of the following: nausea and or vomiting, or photophobia and phonophobia. It's so interesting to me, but when you just straight out ask people, are you sensitive to light? Are you sensitive to sound? A ton of people say no for some reason. So you kind of have, I see some of my residents in the audience. You guys have heard this a million times, but sometimes you have to kind of read between the lines. So if someone says, yeah, like these fluorescent lights really bother me, or you should specifically ask them, do you have trouble with fluorescent lights or screens? Oh yeah, those are terrible. Those cause my headaches. And so sometimes you have to ask those other questions specifically. I have 2 kids. I love them very much. I never like hearing them scream, but when I have a headache, it's even more intolerable than usual. So that's another way to kind of think about asking about photophobia. And so To meet the criteria for chronic migraine, you have to have at least some degree of headache. It can be tension type headache or migraine at least 15 days out of the month. And that has to be occurring for at least 3 months. And at least 8 days of the month have to be sort of migrainous in quality. Or they're believed by the patient to be migraine at onset and relieved by a triptan or an ergot derivative. So words matter. Your patient might say, you know, if you ask them how many headaches did you get this last month, they might say, I got 4 migraines. And then so you hear, okay, that's 4 migraine attacks per month. But really what the patient means is they got 4 migraine attacks, each of which are 2 days. So they had 8 days of migrainous headache. Some people will say things like cluster migraine, which isn't a thing, where they think that, you know, their headache sort of clusters together, which can happen in various other headache disorders, right? But if someone has menstrual migraine, for example, those headaches tend to quote-unquote cluster together. It does not mean that they have cluster headache. Sometimes people, when you ask them, you know, how many days of migraine did you have, they might just tell you about their migraine aura attacks and sort of not even report the migrainous headache that they have without aura. So it's really important to clarify what you're talking about. Okay. Oh, and so probably the most important point about how to distinguish between episodic and chronic migraine is not how often do you get headache, believe it or not. Because if you ask someone, how often do you get headache, they want to tell you about the headaches that they want your help with, okay? They will tell you about the bothersome headaches, the moderate to severe headaches. But unless you specifically ask them about how often they have this sensitive head or this mild tension or this quote-unquote sinus pressure or whatever they think is the cause for this discomfort in the head, you have to specifically ask them how often they're without any discomfort above the neck. So I sort of define headache as any discomfort above the neck, regardless of what they think it's from. And so I say, how often are you completely crystal clear in the last 30 days? And the inverse of that is your headache frequency. So you have to really, really ask about headache-free days to make the diagnosis. And that helps to distinguish between episodic and chronic migraine. So in this case, Erica has episodic migraine. So you'll notice that when I pulled up the diagnostic criteria previously, it says nothing about these other phases of migraine. So don't forget there is migraine prodrome, where people can yawn more often, they pee more often, they have mood changes, they have food cravings. To me, it sounds very much like a hypothalamically mediated process, and that can also impact people's lives. In addition to aura, the acute phase of migraine attack where you have the actual pain of a headache. And then, of course, there's the postdrome, or as I call it, the headache hangover. And then in between all of these phases of migraine, people have interictal symptoms as well. Some people have those sensory sensitivities we were talking about. And so it's important to acknowledge that even though somebody says they had one severe headache attack, there may be this other collateral damage interictally. So explaining the diagnosis. As maybe you can't tell, but I'm kind of nerdy, and I actually will pull up these sorts of pictures from my patients in clinic especially if they're asking, well, what is the cause? There's got to be some cause to explain my suffering. And so I'll pull up these pictures, and I think it empowers people once they understand what's going on. So hopefully you remember that the spinal trigeminal nucleus is the portion of the trigeminal nerve. You all know this, but it's the portion of the trigeminal nerve that deals with pain and temperature processing, right? And remember, it goes all the way down to C2, and in some anatomic studies can go down to C3 or C4. And so it's sort of no wonder that you have this sort of peripheral and central sensitization that occurs with a long-lasting headache that's not treated. So you have these pain and temperature fibers, and these pain and temperature fibers, right, from two different distributions, converging in the same place in the nervous system, okay? And so it's a two-way street. If you have a problem high up in the neck, let's say you have, a high cervical radiculopathy or facet arthropathy, it sometimes can rev up expression of a migrainous headache. And if you have a migrainous headache that isn't well treated, oftentimes people with migraine are, always searching for that perfect pillow. They have a lot of neck tension and stiffness. And that can be explained neuroanatomically with a picture like this. Now, the other part that I like to explain is, you see the picture of the hypothalamus on the right there from the New England Journal. I find talking about the hypothalamus to sort of be an aha moment for patients. So if you are genetically susceptible to migraine and you have a bad night's sleep, you skip lunch, you're about to get your period, you have food cravings, all of these things are probably explained by hypothalamic modulation of this trigeminal cervical complex that we just talked about. And when patients understand that, they're like, oh, so it's not all these disparate things that are, all these different causes to my headache. It's a neurobiological disorder, and I can anticipate when I might be susceptible to this. So as I mentioned before, there are some diagnostic pitfalls. So just because someone has pressure in their face does not necessarily mean that they have sinus headache, quote unquote, although certainly sinusitis can cause bothersome headache. You can have autonomic features with migraine, which can muddy the waters. As I mentioned also, people can have cervicogenic causes of migrainous headache, but a lot of the time it can be related to peripheral and central sensitization from migraine. And tension type headache, remember, it is the most common headache type worldwide, but it's a mild to moderate headache disorder. And because of that, most people don't go to the doctor for it. And so if someone's coming to you for help and they're saying that their headache is severe, it's probably not tension type headache. And so in my own practice, I think this varies among headache specialists, but I think that if people are really honed into their triggers, suddenly they feel like they're doing something wrong to cause their symptoms. And so, one might say, oh man, that was a terrible headache yesterday. What did I do to cause this? I ate ice cream before bed, so maybe I should cut sugar from my diet. And then the next time it happens, I ate a pasta for dinner, and so maybe I should cut gluten. And so there's all these sort of different things that happen, and then at one point someone will say, okay, well, as long as I avoid, MSG, gluten, alcohol, direct sunlight, and my children, I feel great. And so that's no quality of life, obviously. So my take is that when you introduce adequate treatment, or if their natural headache pattern improves, you tend to be less sensitive to your triggers. And so I don't really, I sort of challenge the utility of triggers as a treatment per se. Okay, so I'm gonna hand it off next to Dr. Birch.
I am so happy to see all of you here and that this room is full. We had given a lecture about complex headache cases last night as well, and it was also full. I'm just really happy that everyone is here wanting to learn more about headache and migraine. So I'm going to present case 2. So this is Sheila. She's a 24-year-old woman who has episodes of unilateral, moderate to severe attacks of pulsating head pain with associated light sensitivity. So what is her diagnosis? All right, I know it's early. I know it's early. Everyone visualize some coffee. Unilateral, moderate to severe, pulsating, photophobia, nausea, vomiting. What does she have? Migraine, absolutely, yay. Symptoms are worse with movement, can last 6 hours or so if untreated. Ibuprofen used to work pretty well to get rid of her symptoms within an hour, but it's been less helpful over the last few months. She's having 2 or 3 attacks a month, often associated with poor sleep and stress, which is very common for our patients. And she's never had a prescription medication to treat her migraines in the past. So I wanted to ask each of you, what treatment gaps exist for her and what would you prescribe?
How long is
The migraine, I think we said 6 hours. 6 hours.
Has she tried any other drugs besides NSAIDs or ibuprofen?
No, she's only used ibuprofen because it works well for her in the past and now it's not working. And this happens, she's 24, so this is an age where we sometimes see that migraine can start to evolve or change and become more treatment resistant.
At this point, I would usually just start triptan.
Okay, is that what you would
You
do?
stole my answer.
I know, this is fantastic, we should just ask them.
For the online people, you should.
Oh, it said start a triptan, that's what we heard.
And some lifestyle.
And some lifestyle changes as well. All right, well, we're gonna get to that talk too.
Yeah, absolutely. So I'm going to go against popular opinion here. I think there's two things that I would consider. In the great state of Connecticut, where I'm from, now we can start with G-PANTs. And so in many cases, I might reach for a G-PANT because it's better tolerated in the patient population. Triptans, often patients give me a hard time or have comorbidities. If I'm going to opt for a triptan because of the duration of her migraine, and if, for example, if it's menstrually related, I would also keep in mind the duration of the medication effect. Of the 7 triptans, I would take a look at how long each one's going to last. Excuse me?
With insurance,
Insurance with G-PANs specifically?
without feeling.
It depends on the insurance company. In Connecticut, now even our state insurances, in some cases, are covering G-PANs first, but it can be state-specific.
So now it's going to get spicy because I'm going to disagree. I love this. So yeah, I would probably go with a triptan still, because when somebody takes an acute therapy, they need it to work. And I think G-PANs work for a lot of people, and I will say I agree about the tolerability on the whole. But I think in my experience, I would still, if I were to go to a desert island, I'd still probably bring a triptan. Now, a lot of people, you have to try a couple of different triptans to find the one that works best for them. But I would still start with that and quickly move to the G-PANs if necessary. But that would be my take. And the other thing I think in this patient that's important to highlight is that if they're nauseated and vomiting, that's game over, right? You can't function anymore. So I try not to be pushy about medications as a headache specialist because, if they don't want to treat headache, that's their prerogative, that's okay. But I am a little pushy about nausea medicines because it's just so disabling once that happens. So, and if they're vomiting earlier in their attack, you might want to think of non-oral options. So nasal spray formulations, injectables.
Stop for a minute. I'm covering that later.
Okay, sorry. I just like talking.
She's giving my whole talk.
You're welcome.
All right, so just looking at the various acute treatment options that we have a lot of different classes of medications that we use for acute treatment of migraine. And there was a nice evidence review that was done in the late 2019, I think, and then was updated just a few years ago. And level A evidence for all triptans in all formulations and the G-PANs, all 3 of them that are available for acute treatment, rimegepant, ubrogepant, and zavegepant. Lasmiditan also has excellent evidence. And then there are some non-specific treatments as well, NSAIDs, some of which are actually approved for migraine. There's a celecoxib liquid formulation, and I think it's meloxicam in combination with rizatriptan that's now also FDA approved for migraine, so there's some evidence for NSAIDs. But acetaminophen actually for non-disabling attacks has some evidence for benefit. The combination medication available over the counter of acetaminophen, aspirin, and caffeine may be a favorite of many of our patients, but it is not a favorite of most headache specialists and neurologists because of the caffeine in it and the likelihood of it causing medication overuse headache. The antiemetics, metoclopramide, prochlorperazine, and promethazine, also have some evidence for migraine pain relief in addition to their action as antiemetics. So looking at next generation oral acute treatments in more detail, so we talked about the Gepants a little bit. Rimegepant is available as an orally dissolving tablet, but no repeat dose is available. Ubrogepant is a pill, and I've heard some of my patients say it's maybe a little bit on the larger side compared to the Rimegepant dissolving, but the nice thing about that one is a second dose is allowed per 24-hour period, and then Zavegepant is a nasal spray. No repeat dose is recommended for that one. We're going to dive a little bit more into those and lasmiditan in just a moment. In terms of when to consider them, you've already heard that opinions vary about this, but I think everyone can agree that any patient who has non-response or side effects to 2 triptans should definitely be considered for a Gepant. And one of the nice things about Gepants is that they do not cause vasoconstriction, and so they're not contraindicated in people with cardiovascular risk factors, and we often use them as our go-to treatment in patients who we are concerned about using triptans in. So Gepants in clinical practice, I pulled this graph from a study of Ubrogepant, but that is not in any way to have a favorite. It's simply what I chose. The effectiveness is pretty good for the Gepants in comparison to triptans. They're probably not quite as effective as triptans in terms of pain freedom at 2 hours, but they are very well tolerated. There are very low rates of nausea, somnolence, and the nasal spray can cause dysgeusia. That's not the case with the oral formulations. The contraindications to Gepants include pregnancy, because we don't have a lot of information about them. We'll hear more about that in a minute. Use with the strong CYP3A4 inducers, ketoconazole and clarithromycin. And Ubrogepant should be limited to the 50 milligram dose, and this is probably the most relevant thing to remember about the contraindications, is in patients taking verapamil, because some of us still use that as a headache preventive medication. One of the other really nice things about Gepants is they are not believed to cause medication overuse headache, and in fact, Rimegepant is FDA approved at every other day dosing as a preventive. So they're really nice treatments for patients who need to use acute treatment a lot. We think that's likely to be helpful instead of harmful. Looking at lasmiditan, so lasmiditan targets the 5-HT1F receptors. So triptans target the 5-HT1B and D, and B and D are both anti-nociceptive but also cause vasoconstriction, whereas the 5-HT1F receptor is anti-nociceptive without the vasoconstriction. So if you want a shorthand to think about the ditan class of medications, it's that they're like triptans, but they're okay in people with cardiovascular disease. The major caveat here is that they tend to cause dizziness, somnolence, fatigue, and they can make people feel kind of out of it. And for that reason, there is a specific statement that patients should not drive or use heavy machinery for 8 hours after taking these medications, even if the patient feels that they are okay cognitively. So in my clinical practice, I use them for nighttime or end-of-day rescue, or I use them in patients who really love triptans but have stopped being able to use them, and they should also be avoided during pregnancy. Rescue therapy is what I call the treatment that we use when the patient doesn't respond to the first-line thing that we have given them in that particular attack. So we want to consider it in any patient with significant nausea or vomiting. If they have a very fast onset headache, sometimes we need to have a backup plan because the first treatment doesn't get in fast enough. Anyone who comes in and says, you know, my treatment doesn't always work as well as I want it to, we might need to think about a rescue therapy, and anyone has been to the emergency room for migraine. And here is where non-oral formulations are helpful. We think about injections because we want to get the medication in fast and bypass the GI tract. We think about nasal sprays and suppositories, particularly if there is pronounced nausea or vomiting. The US is one of the only countries in the world where we give oral medications for people who vomit as the treatment. So suppositories actually work quite well, particularly phenothiazide thiazine suppositories, and indomethacin is also available. I often get asked about butalbital combination medications and opiates. They don't have very good evidence for effectiveness. I know people still like to use them sometimes, but their evidence is level C. Those two medication classes in particular have the highest risk of medication overuse headache in longitudinal population-based studies. And they have withdrawal syndromes when people take a lot of them and then stop acutely. So we never use them first line. Some headache specialists may prescribe them in rare cases as a last-ditch rescue to keep people out of the emergency room, but that's not certainly a recommendation. Other things we can do, particularly for patients who have status migrainosis or headache lasting several days in a row, is steroids, and sometimes we just want people to go to sleep, and so we can use sedatives as well. When we are looking more about non-oral options, we have DHE nasal spray, dihydroergotamine nasal spray, and the subcutaneous or intramuscular injection. Patients have to draw it up and inject it themselves, but it is important to know that that's an option if you have someone who you really are struggling with. The triptans, sumatriptan is available as a nasal spray, as well as zolmitriptan, and subcutaneous sumatriptan is available in that formulation. And we're going to hear more about neuromodulation a little bit later. So choosing the right option for our patients. One of the things we want to think about is the speed of onset of attack. So somebody who wakes up with a really severe headache or tends to wake up and their headache escalates very quickly, we may want to think about, for example, injectable sumatriptan or a nasal spray or something that gets in faster. The same is the case with the severity of attack. We may want to use a non-oral formulation, or we may just want to encourage that patient to go to their migraine-specific treatment first rather than trying the NSAID or the acetaminophen or the non-specific treatment. We always want to think about nausea, as we heard, and treat that. And we talked a little bit about when to choose new treatments, including contraindications to triptans or inadequate response. Our patients often don't want to tell us that we are failing them. When you ask them, how's it working, they're like, it's okay, it works, it's okay. And it really helps to be specific with them about their response to treatment. So we have to specifically ask them, how long does it take to work? Does it work completely? Is your headache completely gone? Are you feeling like you're having other symptoms than pain that kind of linger when you take this treatment? Because a lot of patients will tolerate the kind of brain foggy feeling if the pain is gone. Are you having side effects? So sometimes people will say, yeah, it works, and then I find out they've only taken it 3 times since the last visit. I say, why? And they say, well, it makes me too tired. I can't take it during the day, and my headaches always happen during the day. That's not a treatment that's working for that patient, so we need to ask about that. And sometimes, unfortunately, these especially new treatments are expensive, and it doesn't help to prescribe something if the patient can't pick it up from the pharmacy and take it home with them. And patients sometimes really don't want to tell you that they can't afford their medications, so specifically asking about that is helpful as well. Moving on to a question that I think many of us struggle with in clinical practice. It's all well and good for me to sit here and tell you that we have all of these options and they're great options and you should, pick this one or that one. But they don't always work. So let's talk about how do we make the best of the treatments we have when the first thing or the second thing we try isn't effective. So the first thing I always tell patients is to treat early. I tell them to carry their medications around with them, like a little keychain pill bottle or something like that. So they always have them and can take them at onset. We have many studies showing that the earlier a patient takes acute treatment, the better it works. And we even have this really interesting study of ubrogepant in patients who can predict, because of prodromal symptoms, when they're going to have an attack, and found that taking ubrogepant before the headache piece of it even starts is effective. So, the early is getting defined even earlier as time goes on. We can increase the dose. I can't tell you how many times someone comes to me on sumatriptan 50 milligrams saying it doesn't work, and all I do is increase it to 100, and it's like the sun comes out, birds are singing. So use the maximum dose. You can prescribe the maximum and tell them to take half the first time for tolerability, that's fine, but then it should be bumped up. We've talked several times now about changing formulations and the route of administration, for example, to sub-Q or nasal spray, and then we try different medications, either within the same class, such as a different triptan, or switching to a different class, such as a GPANT or something else. And then we can add adjunct therapy, so an NSAID plus a triptan or an NSAID plus a GPANT, adding an antiemetic, and again, many of those antiemetics have anti-migraine pain properties. Ondansetron is the one that doesn't, but all of the other ones do, and they can be a really helpful adjunct, or sometimes we use all three together. And then if all of that fails, we should really be thinking about adding preventive measures. So my pearls for acute treatment: every person with migraine needs reliable acute treatment. There are very few people who land in our offices who are doing fine with nothing. You want to consider migraine-specific treatment in those with moderate to severe attacks. And a lot of our patients are used to getting by. And part of our job is to tell them that they don't have to just get by, that it can be good. We want to consider non-oral in those with nausea, fast onset. And we want to consider neuromodulation or GPANTs when concerned about overuse of acute treatment, in addition to starting prevention.
Good morning. I have the luxury of discussing non-drug treatments with everyone today. So for case 3, we have a 49-year-old woman with a history of migraine with aura since her 20s, and she's coming in with about 4 headache days a month. 2 of these are severe. She's saying that she's having side effects on topiramate and nortriptyline. Sumatriptan works within 2 hours, but it makes her feel awful. She'd like to avoid taking prescription medications if possible. So I have to ask my colleagues here, for these non-drug treatments in your practice, when do you end up thinking about them?
So I love being a headache specialist because it's all about shared decision making. And so if someone comes to me with an interest in a non-drug option, I'm all about it. I think still if someone doesn't bring this up, I would probably, switch them from their triptan to something like your GPANT, which maybe I should have started with. But certainly, if there are other factors that can be addressed without a medication, that's always a win. People who have medication overuse behaviors, or people who are pregnant, or children, there are some special populations that I think might benefit, especially from non-drug options as well.
Yeah, I really echo what you said about it being kind of patient-specific. I think there are some patients who are really medication-averse. I practice in Vermont, where people tend just in general to be a little bit more medication-averse than in my practice in Boston, where I was before, for example, and are really interested in a lot of these treatments. So we really kind of follow what patients want to do and feel comfortable with. I think a lot of our patients have a lot of sensitivities to medications and are concerned about side effects, and it can be nice there. And I also use them a lot as adjunct treatment. So if we just want to boost the effectiveness of our pharmacologic interventions, sometimes it can be nice to layer these things on as well.
Yeah, that's very helpful. And I have to highlight, yesterday I went to this talk on polarities, and how we tend to go towards one end or the other. One person wants to start with triptans, one person wants to go to GPANTs, but why can't we meet in the middle and see what the patient wants, and also give them a toolkit, right? Of let's give you a plan A, a plan B, a plan C, and that may include non-drug options like neuromodulation, so that we have a well-rounded view of different things the patient has as backup. So for our patient, our 49-year-old woman with migraine, 4 attacks a month, what can we consider?
So I conducted a survey study with some of my colleagues in a Facebook group called Move Against Migraine. At the time of the study, around 29,000 people were in this Facebook group, and around 400 to 500 people completed the survey. And these are the evidence-based approaches that they told us that they're using. And the crazy thing is, we know from the literature over 80% of people are using complementary and integrative medicine in addition to their mainstream therapies, but only 50% or so are actually talking about it with their clinician. And so I think it's been really an important part of my practice to ask, what are you doing outside of the practice? So technically, complementary and integrative medicine encompasses acupuncture, craniosacral therapy, mind-body approaches, and nutraceuticals. Neuromodulation is one of those things that has randomized sham controls behind the FDA-cleared devices we'll talk about today. And so they're not technically in that complementary and integrative realm, but more so they're becoming more a part of mainstream therapies. So we can't talk about non-drug treatments without talking about lifestyle modifications. And I heard from some people in the audience that you definitely talk about lifestyle modifications. But as a community, I think we definitely need a lot more science to see these specific connections between genetics, hormones, such as estrogen, our circadian rhythm, and migraine. We know that some people are just genetically predisposed. Specifically, more recently I've been reading about the PER gene mutation, one of the periodic genes which regulates the circadian rhythm. If somebody has one extra repeat of the gene, they need less sleep. They're more likely morning people. And if somebody doesn't have that repeat, like myself, I'm a night owl. I like to stay up late. I like to sleep in a little bit more. I love my sleep, like to have a little extra sleep. So it's so complex, the regulation that our circadian rhythm has on inflammatory factors, the inflammatory cascade, and migraine specifically. So I can't emphasize enough how important this discussion is regarding sleep, nutrition, hydration, and exercise. Because most of the people I see in my practice, especially college students, for example, are not following any of the regimented things that contribute to brain health. So nutraceuticals, these are the nutraceuticals that have evidence for the prevention of migraine. And when used at optimal doses, I oftentimes do recommend adding them to mainstream therapies because most of them have a favorable side effect profile, but I will say the negative is that in the randomized clinical trials that were done with these medications, they included patients who had 2 to 6 headache days a month. And in reality, in a headache practice like mine, I'm seeing people who are having anywhere from 10 to 30 headache days a month. So for my purpose, I tend to use them more so as an additive to mainstream medical therapy. Some of these are also helpful to counteracting side effects from mainstream medications, preventive therapies, and also helping with some of the other medical comorbidities they have. For example, I have a lot of patients who have chronic constipation in the migraine world, whether it be due to their preventive treatments or other medical conditions. So magnesium is very helpful in this population. I tend to go for magnesium glycinate for better absorption, but I do tend to start the dose low and increase very slowly over a few weeks. And so any of these can end up being very helpful to consider as an additive approach. The folks with sleep issues in general and who need help re-regulating that circadian rhythm, melatonin can be a very helpful approach to take 2 hours before bedtime. Vitamin D is a lab that I am checking more in my patients with migraine because most people where I am in Connecticut are very deficient. And so it's a very easy thing to add into the regimen for me and tends to make people better part of the time, so worth considering. Mind-body therapies are so important as an add-on to mainstream therapies because it really helps patients work on their thinking and their coping skills. Specifically, biofeedback cognitive behavioral therapy have pretty good evidence for the prevention of migraine. So we'll go into these a little bit more, but very much worth considering for not just migraine, for overall brain health. And in a time where people's minds are so chaotic and there's a lot of trouble with focus, it's oftentimes worth adding this into mainstream therapies. And I know that, in many cases, we start considering these non-drug approaches when somebody's having side effects to medications, or they're having an inadequate response or contraindication. But I find that talking about these approaches earlier, patients are more likely to buy into the treatment plan we're coming in on together. Oftentimes, when I only talk about drug approaches, they think psychologically that, oh, she's just trying to prescribe medications, right? I mean, everybody's heard that, I'm sure, I would think. So I try to discuss natural approaches if their mindset is in that place about, I want to go natural. I hear that all the time now where I am. So cognitive behavioral therapy, in this day and age, it's really amazing because 15 years ago, we oftentimes had to refer to a pain psychologist for cognitive behavioral therapy. The treatment would be so expensive for patients, and so they wouldn't pursue it. But nowadays, there are apps available. There are online psychotherapists, psychologists, and even some trained social workers who can do cognitive behavioral therapy with your patients. So it's accessible just through their iPhone. Cognitive behavioral therapy I found to be so helpful I see people who are 8 and above, so I see children, adolescents, adults, in all of these phases of life, and it really helps them completely reframe the brain and retrain the brain to really help them think about their pain differently. Biofeedback, this is one of our colleagues from Stanford, Dr. Zhang. This is using a sensory feedback to teach patients to relax their muscles, control their breathing, regulate their heart rate. It's the technology that's come up in the last few years is amazing. I had so much trouble finding biofeedback clinicians within my state or close by anywhere. So there is a really interesting company available now called Jago Health, where it's FDA cleared specifically for a revised form of biofeedback, FDA cleared for migraine and other chronic pain syndromes, and patients can use an iPad and a portable device to apply a muscular stimulation in the area they want to learn to relax. And so they can do that either with a clinician or buy the device to use at home. So in this new wave of technology, there's so many new things that are available, and we don't have to have a patient wait 9 months or a year to get these treatments. And relaxation training, my patients love using, so many apps are available now, such as Calm, Headspace, Juva, to teach patients guided imagery, diaphragmatic breathing. And when they add this in, it's going to help their mental health comorbidities too. Neuromodulation, we have 5 FDA-cleared devices for the acute treatment of migraine, and 4 of these are also approved for the prevention of migraine. 3 of them, single pulse transcranial magnetic stimulation, our vagal nerve stimulator, and remote electrical neuromodulation are also cleared for adolescents. And this is a population where mom and dad, parents really want to consider non-drug approaches. And so in particular, patients have reported to me that remote electrical neuromodulation has been helpful because it's an armband that can be worn under the clothes, and they can regulate it with their iPhone. And it works by stimulating the nerve fibers in the arm and doing conditioned pain modulation back to the pain centers in the brainstem. These devices have various cost points. Most of them are not covered by payers. Some of them, remote electrical neuromodulation can be put through insurance, but most of the time it's tough to get that reimbursement. The two most popular ones in my practice among patients are supraorbital transcutaneous nerve stimulation, which is the Cephally device, and remote electrical neuromodulation, which is the armband. I'll just highlight here that single pulse transcranial magnetic stimulation is the particular one that I consider for patients who have aura, because it's specifically working at the level of cortical spreading depolarization. I'll need a whole other lecture to go through cost points, so I'm just going to skip that for now. There's a wide range, find me after. So the treatment plan for this patient, we ended up starting her on magnesium, riboflavin, coenzyme Q10. We referred her for biofeedback, and we switched sumatriptan to almatriptan to maybe try a different medication in the class that has a longer half-life. Would you do anything differently, guys?
Go ahead. You go first.
No, I don't think I would necessarily do anything differently. I think optimizing acute treatment in this case makes a lot of sense. And I think when patients ask about devices, I generally am very responsive to that and really follow their lead, giving them my knowledge and then giving them the device if that's what they're looking for. And then I really like to layer in either relaxation or mindfulness or biofeedback. So I think that all of those things are mentioned here.
Yeah, I think the other point I would make is that as we're biased because we're headache specialists, but it's important to acknowledge that there's a cost to only relying on these things. So if we didn't provide the triptan or appropriate preventive therapy, if that's the case, then if you're only relying on these things, there is an opportunity cost, right? And so they may find that their headache isn't well controlled. They, have to miss work, have to miss school, and so I think these are really important tools to help bolster that toolbox that we're talking about. But have a conversation with your patients. Look, if you're not doing well, I want to hear from you so that we can better optimize things. And have these other therapies be driven by patient interest and cost.
Yeah, that's a really good point. I mean, talking about cost with patients is inevitable, right? For all of us. It has to be a realistic plan for the patient.
Okay, so we're going to move on to talking about preventive treatments, and we're going to talk about Devin, who is a 36-year-old lawyer. He's had migraine for 16 years, and over the last 2 years, they have gradually gotten worse, and he's now having 2 to 3 attacks per week. He has been using a triptan for acute treatment. It's not consistently effective, and he ends up missing work about once per month. So we're going to talk about when to consider preventive treatment. And I just want to say, before we talk about the specifics, that prevention is really underused in patients with migraine. We tend to wait a long time before the commitment to put someone on a preventive treatment, and it does result in a fair amount of suffering and undertreatment in our patients. And so I really encourage you to start leaning more towards thinking about starting prevention earlier, because we know that so many people who are eligible, according to expert consensus, are not given it. So when to consider it is significant interference with activities despite acute treatment, attack frequency greater than 1 per week, that's 4 a month. Elevated risk like medication overuse, headache, or daily headache, if acute treatment is ineffective, contraindicated, or used more than twice a week, because we worry that patients are then at risk for medication overuse headache. Anytime a patient comes in and says, look, I just need this to go away, I don't care what it takes, like we may think about putting someone on prevention if they have 3 attacks per month, but they're severe and disabling and nothing is working and they just want them to go away. And then some uncommon migraine types with very severe aura, such as brainstem or hemiplegic aura, we may think about starting people on prevention earlier. So our patient has a couple of these characteristics that make us think about starting prevention. And I mentioned that disability and frequency of attacks are kind of a matrix that inform one another. And basically, when you have more severity of attacks, you need fewer of them in order to start considering preventive treatment. If someone is having much more moderate, non-disabling attacks, they can usually put up with a few more of them per month before we start thinking about starting prevention. At the time that we start preventive treatment, we want to be clear with patients about what the expectations and goals are, because it's not no headaches. I wish that it was, and I will say that with some of the newer treatments, I am seeing more patients who come in with no headaches or very few headaches, but it's not something that we can always promise our patients. And if someone comes in with a reduction in attack frequency of 50% or more, so they're having half as many attacks, we feel that that treatment is working and we're going to keep going with it. We may not be done, but we're definitely going to keep working on that particular avenue and layering on. So the goal is to reduce by 50% frequency, duration, intensity. We want to improve response to acute medication. We want to reduce the frequency of acute medication, and all of those things together are going to reduce headache-related disability. I wanted to talk specifically about the medication overuse headache treatment approach, because there has been some question, discussion, and disagreement about how we should approach this. Historically, the advice given was always, okay, well, if you have medication overuse headache, you need to stop whatever the overused acute treatment is, and once you've done that, you can come back and talk to me about what to do next. How often does that work? Never. Very rarely. There are a few very motivated patients who are like, okay, I'm going to go do this, and they do it, and they come back, and they do great. But a lot of them can't do it. And so one of the questions that was asked in a trial that was funded by PCORI and headed up by Todd Schwett was whether adding preventive treatment as the sole intervention, so you can continue your overuse treatment for now, but we're going to just start prevention and see what happens, versus starting prevention and switching to an alternative acute treatment that's less likely to cause medication overuse. And what they found was that the outcomes in those two groups were the same. So the secondary outcome was that the switching group had reduced their consumption of medication by half, so versus about a third in the non-switching group at weeks 9 to 12. But in terms of moderate to severe headache days, it was about the same. So the conclusion is that for patients with chronic migraine and medication overuse, the efficacy of starting or optimizing preventive medication is not dependent on whether patients first reduce their use of acute medication. In other words, to put this very simply, having medication overuse is not a reason to avoid prevention, it's a reason to start prevention. So if you have someone with medication overuse, the kind thing to do is to start prevention in addition to working on their overuse treatment. So we have a lot of different options for the preventive treatment of migraine. And this is a little bit of a moving target, this chart, because evidence comes out all the time. And different groups work on synthesizing the clinical trials and the evidence that we have and ranking things and coming up with categories of effectiveness all the time. And the American Academy of Neurology is in the end stages of their update to the 2012 guidelines. We have had a preview. There was a version that went into comment over the summer, so we have some inkling of what it's going to show, but the final version is not out. What we can tell you is that pretty much everybody agrees that all of the CGRP monoclonal antibodies and onabotulinum toxin A for chronic migraine specifically have established efficacy. Atogepant, candesartan, divalproex, the beta blockers, metoprolol and propranolol, timolol, and then the anti-seizure medications, topiramate and valproate, all have really high evidence for effectiveness. And then there are some that are in the probably effective category, which includes amitriptyline, venlafaxine, and a number of other things. So before I go on, I actually just wanted to do a little audience poll here. So I don't know how many of you were at the plenary session yesterday where there was a debate about whether CGRP targeted treatments should be first line, and certainly opinions vary about that. So I just kind of wanted to ask you this question. You're going to a desert island and you have 100 people on it who have migraine. How many of you, if you're bringing one treatment, how many of you are bringing a CGRP targeted treatment as your only option? Show of hands.
Regardless of cost?
They're on a desert island. It's yes. There's no, yes.
No limitations?
No limitations.
Sky's the limit.
Yep, regardless of cost. Yep, this is like, we have institutionalized social medicine on this desert island of 100 people.
Sign me up.
How many of you are bringing a CGRP targeted treatment? How many of you are bringing something else, a non-targeted, non-CGRP targeted treatment? Okay, just a couple of answers. Shout out, what would you bring that's not a CGRP targeted treatment? Propranolol, anything else? Okay, anything else? Okay, what would you bring?
Just one medication, right?
Just one.
Atogepant.
Okay.
Because I found that regardless of medical comorbidities, for the most part, it's pretty well tolerated, and I've seen patients get better within the first week because of the half-life, the onset of action.
I think I might bring fremonezumab because I think the tolerability is really great. And you know, you don't have to give the loading dose, and less side effects than the others in the class. Atogepant's great too, you know.
You need a refrigerator on that island, though, for fremonezumab.
I mean, where are you going to put the margaritas?
All right, so I'm going to be terribly contrarian here. I would bring amitriptyline.
Dr. Rizzoli would be so proud of you, Rebecca.
I know he would. He trained you too. Because I only get one treatment and it treats a lot of different things. So one of the things about amitriptyline is the clinical trials that were done are very old and they don't meet modern criteria. So I think it would look better if we studied it now, but that's okay. So you heard yesterday that the American Headache Society does support the use of CGRP targeted treatments as one of the first line options. Most insurances gatekeep them behind one or two preventives currently, but that's, I think, very much an evolving discussion. So talking specifically about the different CGRP monoclonal antibodies, and I think in some ways, you know, we've shown the slide like this for several years, and I think everyone's getting pretty comfortable with them, so I won't kind of belabor it, but there are 4 of them. 3 of them are subcutaneous. 1 of them is intravenous and given quarterly. They are all very well tolerated. Galcanezumab and fremonezumab are more likely to have injection site reactions. Arenumab is more likely to cause constipation. All of them now, this is actually now outdated as of last week, all of them have concerns about worsening hypertension now. And questions that we often get asked about CGRP monoclonal antibodies, can you use them in people with episodic migraine, or are they like onabotulinum toxin and only for chronic migraine? And the answer is that they are approved and effective for all migraine, including episodic. Can you use them in combination with onabotulinum toxin? Yes, you can. And for reasons I don't have time to go into, they may actually have a synergistic preventive effect and help them each work better. Do they work in patients with refractory migraine? Yes, they do. So very much kudos to the manufacturers of these treatments for looking at them in populations that more closely resemble the patients we see in practice. All of the CGRP monoclonal antibodies have trials in people who have failed at least 2 prior treatments, and they work just as well. They work with medication overuse. They work in patients with different comorbidities. They sometimes do start working pretty quickly, as Dr. Kuravilla had said. And in terms of how long we should wait to determine effectiveness, there are differing opinions about this, but I think 3 to 4 months is probably reasonable. And then how do real-world results compare to clinical trials? Effectiveness is about the same, but maybe we see higher rates of constipation and hypertension with Erenumab in real-world trials compared to the clinical trials. So I wanted to ask you a little bit, what do you experience when you give these treatments to patients? Do you ever switch from one to another? What do you hear patients telling you?
Certainly. This is so variable, and I do switch between agents. I have to highlight that I don't use Erenumab much more in my practice now because the label's been updated with oral ulcers, alopecia, hypertension. So because of the side effect profile, I do tend to go more towards fremanezumab, galcanezumab, and our infusion formulation, or of course atogepant, right? That's the biggest thing, but I definitely switch between one and the other classes.
Yeah, I often switch as well. I think if somebody already has, the opposite of constipation chronically, I'll be like, I've got a drug for you. But I also don't really use Erenumab that much in my practice. I do think if somebody has like a lackluster response to a ligand targeting monoclonal like fremanezumab or galcanezumab, there is, I think, rationale to consider Erenumab, but you just have to talk about the potential for side effects. And not only with Erenumab, but also with the GPANs, some of my patients have pretty severe constipation. Most people don't, but you have to remember to ask about that specifically because people sometimes don't want to volunteer that, and it can be quite severe in some select patients.
So one of the things that we have found really interesting over the last several years in talking to our patients is, everybody hears about one-off side effects with treatments. You ask, are you having any side effects? And they'll come in and they'll say things like, well, I'm having menstrual irregularity, or, my mood has changed, or my hair is falling out. And we kind of shrug and say, okay, well, we have no idea whether this is related to the treatment or not. It's not on the label. And some of the time it is just sort of hypervigilance about it being a new treatment, and people are connecting dots that are not necessarily there. And sometimes it turns out that they're actually reporting something that a lot of other people are reporting as well. And one of the things we found really interesting was our patients had started to report hair loss, and we were talking about it and we're saying, hey, have you heard anybody, say this? Oh yeah, I've heard a couple of patients say this. And then it gets added to the label because it turns out that a lot of patients have it. So it's important not to necessarily dismiss side effects as it being impossible to be related to the treatment. In terms of choosing between all of the preventive treatments, one of the things to consider is comorbidities. We know that migraine patients have a lot of comorbidity, and chronic migraine has more comorbidity than episodic migraine. So the more severely affected by migraine our patients are, the more likely they are to be affected by other things as well. Comorbidities complicate migraine diagnosis, and very often migraine gets attributed as a side effect or being due to some of the other comorbidities. The other reason comorbidity is important is that it informs and limits our treatment choices. Polypharmacy is one way that it does this, and then simply a contraindication to medications is another, particularly cardiovascular risk factors. Last night we heard a whole lecture on treatment of migraine in patients who have hepatic and renal and cardiovascular disease, which was excellent, and I recommend that you go back and see it if you missed it. So how to choose? Patient preference is really key here. We always talk about shared decision making, but I can think of no place it's more important than when we are starting preventive treatment, because we have so many options and because the side effects really differ between the treatments, and we now have oral versus injection. We have different intervals of treatment. So you really just have to ask, what do you care about? What are you willing to do? What do you want? And I often sort of present a couple options and let them pick. And I think having that buy-in also increases adherence, because a patient who feels that they were part of the decision feels agency, like this is my treatment. It's not something I'm being told I have to do. So obviously, we just want to understand what our target is, so getting a good sense of headache frequency, disability, what associated symptoms bother them, and then really thinking about those comorbidities as well, including sleep disturbances and anxiety and weight and things like that, which may influence our choice of treatment. Guidelines for when to start the new treatments. So the American College of Physicians guideline was released a couple months ago, and this is, I think, part of what has kicked up the dust a little bit in us talking about where these monoclonal antibodies fit in the treatment algorithm. Their recommendation was to try either metoprolol or propranolol, valproate, venlafaxine, or amitriptyline, one of those, as a first-line treatment. And if the patient does not respond to whatever it is that you pick as your single trial, then you go to a CGRP antagonist or a CGRP monoclonal antibody. And interestingly, despite the fact that topiramate actually has probably the best evidence of all of these other older treatments, they put it as number 3 behind the CGRP targeted treatments due to concerns about tolerability. So all of that is in contrast to the American Headache Society position statement, which is that the CGRP-targeted treatments should be considered among the first-line options. And again, we've said this multiple times. I feel like it's kind of the headache theme of this meeting this year. This is going to be evolving. So pearls, disabling attacks, poor response to acute treatment, frequent use of acute treatment are all good reasons to start prevention. In patients with chronic migraine and medication overuse, you should start prevention while you are working on the overuse of the acute medication. One pearl is that many patients with migraine are very sensitive to side effects. There's actually studies showing that people with migraine are more sensitive to side effects of medications than people without migraine. So we often start low and increase slowly in order to balance tolerability with effectiveness. We don't want to lose a treatment by starting it too high or increasing too quickly, and then shared decision making should be used when we're starting treatments. And I guess I moved my desert island too early, but I asked the question. We can all admire the desert island.
So on your slide right before the pearls,
Yes.
you have ACP and then you've got Asia.
Yes.
Payers, are they weighting one opinion more than the other? Like, how are we going to
So, okay, so the first thing to say is that there's variability. It depends on, it goes state by state and insurance by insurance. Most insurances are still requiring 1, if not 2, trials of older preventives before covering CGRP targeted treatments. So that's still what I would expect for most of you to see. I also anticipate that that is likely to change in the upcoming years. How fast, I don't know, but there's significant pressure being placed on payers from a lot of various sources to make that change, and it seems to be moving things, whether it's right or not.
All right. So just when we're starting to talk about how confusing all these guidelines are, we're going to talk about pregnancy. So just sort of the Wild West. I will say, so I'm a residency program director, University of Buffalo. Hi, residents. And sometimes I'll get called by the residents who staff someone in their continuity clinic who's pregnant, and they're like, Dr. So-and-so just said, well, it doesn't last that long. People are afraid to treat pregnant patients with headache, and so they'll call me, and I'm like, you guys know what to do, come on. So don't be that person. Have a discussion with your pregnant patients. There are options, and again, weigh those benefits and risks. So let's start with another case. We have a 35-year-old woman with a history of episodic migraine without aura. She's now 14 weeks pregnant and experiencing an increase in migraine frequency in the past month. Prior to pregnancy, she had 1 to 2 migraine days a month that were effectively treated with rizatriptan. In the past month, she's been having 3 to 4 migraine days per week. That's a lot. No change in the character of headache, normal neurologic exam. She's at 14 weeks, so usually after 20 weeks is when you start to think about more sinister causes of headache. So how do you talk about the options even before pregnancy? 50% of pregnancies are unplanned, right? And then what do you tell patients to expect during pregnancy? How do you navigate this, guys?
I think that as far as the first question goes, I think that the landscape of fertility has changed so much in the last 15 years, right? A lot of patients are going through egg freezing procedures, in vitro fertilization, and intrauterine insemination. And so I always have a conversation with my women of childbearing age about their plans. And many of these folks, for example, I have this 32-year-old woman I saw a couple of weeks ago who went through the egg freezing procedure, and she had to be on several different hormone modulating medications. So we came up with a plan for what we call situational prevention or mini prevention for her to start before her treatments. So I start the conversation very early.
I also start the conversation very early, asking about contraception and potential plans for childbearing is part of every initial conversation that I have in the appropriate patient demographic. And it is really nice when we can get patients while they're still thinking about it and not after the fact. I have definitely gotten the panicked phone call many times saying, I'm on X treatment, what do I do? But when we can get patients ahead of time, the most important thing is to reassure them that we're there, we're not going to abandon them. A lot of our patients really are very afraid of this. Because they believe that there is nothing they can do, and many of them have very severe disabling attacks and have a lot of fear of having to go through that without treatment. And so reassuring them that there are treatments available is really important. And then, I think we're gonna, talk about the plans that we come up with, but really just going through and having a concrete plan is really helpful too.
All right. So there are options. So some preventive treatments to consider, there's a degree of lifestyle modification. You can talk about nutraceuticals, behavioral therapies, oral preventives, Onabot, nerve blocks, neuromodulation, acute treatments to consider. Acetaminophen and metoclopramide are really my go-tos for acute treatment, which we'll talk about in more depth. Triptans, I think, are a very reasonable second-line therapy, in my opinion. With accumulating evidence for that is reassuring, so we'll talk about that too. And then again, neuromodulation and nerve blocks. So there was a systematic review in 2021 that sort of, I think, confirmed what we were all sort of already putting into our practices. So for example, calcium channel blockers and antihistamines, they said, may not be associated with adverse events. And as I mentioned, for acute treatments, triptans may not be associated with adverse events with accumulating evidence. And so that is somewhat reassuring. And then the ACOG, American College of Obstetricians and Gynecologists, in 2022 came out with this clinical practice guideline that, I personally have a lot of difficulty kind of reconciling all these different guidelines. It sort of makes my head spin. And, you're all already feeling nervous about treating a pregnant patient because you're essentially treating two patients, right? Basically, what ACOG recommended for acute treatment was acetaminophen was recommended, caffeine at less than 200 milligrams per day, diphenhydramine that really does not have a anti-nociceptive effect that much, but it can be a helpful adjunct. And then metoclopramide, as I said, has a history of use and pretty good safety profile in pregnant patients. Remember, metoclopramide will help treat the nausea associated with the attack, but it also has anti-nociceptive properties to it, okay? And so in the same year, which is kind of awkward, I authored a manuscript for Continuum talking about headache and pregnancy. And so this was sort of my table. I might actually make some changes now, a couple years out from here. But in general, again, you see metoclopramide, acetaminophen. I also put lidocaine in there. So not only can you use lidocaine in peripheral nerve blocks, I actually, it was published in the Lancet in the 90s. I usually give patients some lidocaine that they can get with a little syringe and give themselves sphenopalatine ganglion blocks at home themselves. I know I'm seeing some faces like, it's safe, and if it helps, great. If it doesn't, move on. You know, and triptans, I think, because they are, you know, really the gold standard after NSAIDs, in general for migraine, I think triptans may have a role in patients who don't respond to these initial therapies I've talked about. The GPANs have not been studied adequately in pregnancy, so I don't recommend them. And then, of course, you all know ergots are contraindicated. A lot of the obstetricians still love butalbital, and it's not really recommended for acute treatment of migraine anyway, and so I think there are more appropriate and effective treatments out there to lean on. So let's see here. So in 2021, there was a systematic review that looked at triptan use, and triptans were not shown to really increase the risk of pregnancy outcomes when compared to the general population. And there are also US and European registries that have been going on for years and years that don't really show a signal for teratogenicity, which is reassuring. There was, of course, the initial theoretical concern because triptans have a vasoactive effect that it may impede the fetal placental circulation. And so luckily, these studies, these registries have not really shown that to be significant clinical concern. So going back to ACOG, this is what they recommended for prevention. So ACOG loves the calcium channel blockers, and so does Dr. Birch, I might add. So they recommended as first-line preventive therapy amlodipine, ciprofloxacin, diphenhydramine, which again doesn't really have much anti-nociceptive benefit, and nifedipine and verapamil, and potential associated risk, none. So I was sort of surprised. I do use calcium channel blockers in my practice for patients who are not pregnant, but not necessarily as first line. So this was a strong statement from ACOG. Is anything missing here? Yeah, so a lot of times people, when they talk about preventive therapies in migraine, we talk about propranolol, which has had a long history of use in pregnant patients, and then Onabot, some folks might consider using in pregnant patients, but that's another area of controversy. So there was a lot that was sort of missing, I think, from that last slide there for first-line treatments. So let's talk about Onabot in pregnancy. At the end of the day, we just don't have a ton of evidence to really reassure ourselves, but the evidence that we do have seems to be somewhat reassuring. And so we have about 500 cases of Onabot use during pregnancy that have been reported. There was a 29-year study, a safety study done by Allergan, including just under 400 eligible pregnancies. 30% of them were, the Onabot was given for migraine specifically. 95% of the use was prior to conception or in the first trimester, and there was no increased signal of teratogenicity. And then there was a case series of about 55 patients treated with Onabot for chronic migraine throughout pregnancy. So then we can start to think about, okay, well, how did this affect pregnancy outcomes, for example? And it's only 55 patients approximately, but they did show live full-term births of healthy babies with no organ malformations. So that's nice, but it's not that many pregnancies to hang our hats on. In my own clinical practice, this is my opinion, but my approach is to continue Onabot up until a positive pregnancy test, because 2/3 of women improve with their headache in pregnancy, and so I want to see if we can ride that natural wave of improvement. I don't hesitate to restart Onabot if someone is really struggling throughout their pregnancy and you've ruled out secondary causes. But I hesitate to start Onabot in a toxin-naive patient because it takes a while to see if you're responding to Onabot. And so are they going to get better anyway? So that's my personal approach. And raise your hand if you've given Onabot to patients in pregnancy. Okay, yeah, so people do it.
You don't take the OT from the OBGYN?
I'm sorry?
You don't take the OT from the OBGYN?
Oh, the question is, do you get the okay from the OBGYN? Great question. And I should have prefaced this whole section by saying it's really important to have a discussion with the patient's obstetrician and make sure you're on the same page. For the most part, I think obstetricians in my area are pretty on board with this stuff, and they see pregnant patients being undertreated all the time, so they're like, yeah, let's treat this person. Occasionally, I will get some pushback, and we have a discussion, and of course, the patient has to drive the decision-making process there. But great question, thank you. So the CGRP monoclonal antibodies. Even though I said that I would probably take one to a desert island, remember, they stay in your system 5 or 6 months after the last dose, and 50% of pregnancies are unplanned. So every time I prescribe one of these to a patient of childbearing potential, I tell them, look, I don't know if you're gonna, plan on a family anytime soon, but you should know this about this medication. So IgG, crosses the placenta through the neonatal FC receptor at 20 to 22 weeks of pregnancy and allows for placental transport. CGRP regulates uteroplacental blood flow and uterine relaxation, which is important. And so we wonder if CGRP might play a role in preventing eclampsia, preeclampsia, and hypertension in pregnancy. Animal studies have looked somewhat reassuring. But again, because of these long half-lives and because of the theoretical risk, I recommend that patients avoid this class of medication 5 to 6 months before attempting pregnancy. In the interest of time, I will not read this entire slide to you, but just say we just don't know enough yet. There's some studies that have been published about CGRP monoclonal antibody, CGRP antagonist use during pregnancy, but we just don't know enough at this point to say with any confidence. There are pregnancy registries available for all these treatments. So I implore you, if you do have a patient that gets pregnant on these medications, please, encourage them to participate in these registries so that we can get more information about how our patients do in response to taking these medications.
If they're taking it while they're pregnant or was taking it before being pregnant, then stop it.
Right, exposure, yeah. Mm-hmm. Okay, and so in terms of preventive treatments in pregnancy, this again is from my Continuum article in 2022. I would still probably make some changes on this. So I should have said this before, but I have the medication on the left and then a safety column and effectiveness column. The effectiveness column tries to sort of wrangle with this, tension that exists between efficacy of a medication and tolerability of a medication. And so I sort of combined the two and said whether or not they're effective. And then you have to also wrangle with safety for the developing fetus. And so there's so many things that are separate issues that are all important to take together, and that's probably in part why all these guidelines are just sort of all over the place at this point. And then, of course, this all may change when the new AAN guidelines come out, hopefully shortly, so take this with a grain of salt, please.
I have a question. For the propranolol, do you talking about tapering from the end of the pregnancy?
Yeah, the question is about propranolol. Yeah, so there are some risks, especially around delivery, and so ideally you could slowly taper and decrease and stop the drug before delivery. we're gonna hold most of the questions for after, because I love the questions. You guys are a feisty audience, I love it. But we'll save time for questions at the end. Don't forget that devices can be used in pregnancy as well. So for this patient, obviously we'd want to rule out secondary causes that would be less likely at 14 weeks. Lifestyle modification, again, probably ineffective alone for somebody who's having disabling attacks. We did start magnesium for prevention, and we did some peripheral nerve blocks with lidocaine. For acute treatment, we leaned on the metoclopramide and acetaminophen that I use more often. Occasional rizatriptan use when those things fail. And then we also talked about neuromodulation. So what would you guys do?
I think this is pretty on par with what I would do. As far as acute treatment goes, I'll just add to something you said earlier. A lot of the compounding pharmacies in my area do lidocaine. And so lidocaine nasal spray, they can formulate it in a very comfortable formulation as well.
In patients without contraindications, I am moving faster and faster to triptans without making people try acetaminophen and metoclopramide first, especially if it worked for them, triptans work for them, and they haven't responded to those things in the past. So I might just continue the triptan, but that's the only thing that I would do differently.
Yeah, I actually talk to them, especially if they're already on a triptan. I say, keep it in your medicine cabinet, because if these two things don't work, don't mess around with, trying them over and over again. I think benefits risk, if it were me, I'd probably continue my triptan if I was having disabling attacks. So I have that conversation up front with them. All right, last case.
Right. So I'm standing between you all and the questions. So I will try to keep it brief. Case 6, Sadia is a 48-year-old woman with chronic migraine. Let me just pause here. Many of the people women we've discussed today are between 40 and 50. And I have to say, that's what I see in my practice too. A lot of people in the perimenopausal phase. And I just was speaking to one of my colleagues in England who's more of a hormone expert in migraine. And it's just crazy. These days, perimenopause can start 10 to 15 years before actual menopause hits, which is being without a period for 1 year. And so it's really important to always look at that age of the patient, because you can address so many of the perimenopausal symptoms very early, starting in the mid-30s now. So, side note. 48-year-old woman with chronic migraine, reduced severity and frequency with Anabot AN topiramate. She's still having daily headache with 8 severe days a month, and she uses her oral triptan for severe days, NSAIDs for moderate, and her REN device for her milder days. She's missing work 2 to 3 days each month when her rescue of intramuscular ketorolac doesn't work. She asks if she can be on any new medications. I hope the answer is yes, right? From all the options that we've given today. How do migraine attacks affect your life? Raise your hand if you've had a severe migraine attack. All right, yeah. How many people have missed work or a leisurely event, family event from a migraine attack? That's a lot of people in the room, right? I'll tell you a quick story here, because it's just an unforgettable story. I was seeing this 96-year-old woman, fully functional, very spunky artist locally where I was living. I had been seeing her for many years for migraine. She was doing so well. But then suddenly her headache frequency picked up right before she was going to go on a safari to Africa at 96. She was really cool and spunky and colorful purple hair, and anyways. So she ended up having to cancel her safari to Africa because her headache frequency went up. She never made it to Africa. She was also an animal rights person, and then she died. So it's all these, really missing these big life events, and missing work is one thing, but life matters too, right? For many of us, these big life events, kids' graduation and stuff. So ask your patients what they're missing. It's really important. What's the definition of refractory? Here's the timeline. The definition of refractory has evolved so much. In the early 2000s, our colleagues would say that it's migraine contraindication or failure of 4 preventive classes after they've had an adequate trial, Now, fast forward to 2020, the European Headache Federation actually divided the terminology up a little bit into resistant migraine and to refractory migraine. What really differentiates them is 3 preventive treatments. So with resistant migraine, that's in folks who have tried 3 different preventives at optimal doses, and this is a bit tall order, but refractory migraine is for folks who have failed all preventive treatments. Most people, when they come to me, they're in the resistant phase at the headache center. They've seen their primary care provider or someone else, and they've tried 3 preventive treatments at some point. Not at adequate doses, but they've tried them and had side effects. And then once they come to me, that's when, unfortunately, in some cases, the refractory journey may begin, and they're failing everything, and we don't know what to do. This is a narrative that I wrote with my colleagues a couple of years ago, just with some practical tips on how to approach this population. Oftentimes, I see people starting a preventive and then switching, starting. But in many cases, we want to make sure to layer treatments. We were talking about polarity earlier. Everybody has their favorite preventive and they don't want to jump to the other side. But many times, it's good to meet in the middle and layer your, if it's the beta blocker you like, with amitriptyline, if it's at an optimal dose, with your gepant or your monoclonal or whatever it might be. You want to give the patients a preventive treatment in addition to acute treatment. There is also data out there that we can prevent the progression of episodic migraine to chronic migraine by optimizing acute treatment. So some patients who come to the office, they say, okay, I had 3 migraine attacks this past month. All right, well, that sounds like episodic, but each individual attack is lasting them 3 to 5 days. So if they're able to get rid of the attack on day 1, then we can really prevent those subsequent days and prevent chronification. And then, of course, my colleagues talked about earlier addressing comorbidities. Combination therapy. This was a really interesting study where Anabot A was injected into the dura of directly injected into the dura, and it was found to block unmyelinated C fibers in the pain pathway. And we have also found now that atogepant specifically blocks A-delta myelinated nociceptors. So in my practice, at least, what I'm observing is that there may be a synergistic effect between our patients who are on Anabot A and our CGRP preventive therapies. So we're kind of working on the pain pathway at 2 different nociceptors. Here's another study that specifically looked at Anabot A and the potential effects of adding in a CGRP monoclonal antibody. And interestingly, patients saw that they went from 15 to 25 days of migraine a month to 6 to 11 migraine days a month. And they had an improvement of 3 to 4 days less of migraine days when they added a monoclonal antibody to Anabot A. And in some cases, we know that patients have that wearing off of Anabot A, right? Realistically, some patients tell me it starts wearing off between 8 and 11 weeks in some cases. And so sometimes we do need that monoclonal antibody or a gepant to bridge that gap for patients. And what's our rationale here? We know that there's some of the preclinical data that shows a synergistic effect. And we have also specific data for fremanezumab, our CGRP monoclonal antibody, that it's also working at the level of the A-delta myelinated fibers, just like we saw with atogepant. And we know that Anabot specifically works at the unmyelinated C pain fibers. So it's a consideration in your practice, adding these 2 modalities together, and again, layering treatments to really see a greater efficacy in your patients. So would you use a CGRP monoclonal antibody and a gepant? The answer is there is no drug-drug contraindication between a CGRP monoclonal antibody and using an acute gepant, using a gepant for acute therapy specifically. I regularly do it in my practice, and we're not seeing that there's a change in the PK of ubrogepant when we do co-administer our monoclonal antibody and ubrogepant as needed together. What about our monoclonal antibody, real-world efficacy for ubrogepant? This is a study that was done by one of our colleagues, Dr. Chiang, who she specifically looked at the use of CGRP monoclonal antibodies and GPANs, and she didn't see that there was any difference in the good responder rate or adverse events compared to the non-CGRP monoclonal antibody user. So we think that those who are taking those CGRP monoclonal antibodies with adverse events, that side effect profile may be more moderate when you do both together than mild side effects. In my practice, I usually monitor for constipation, which may be exacerbated when you're adding your ubrogepant with your monoclonal antibody, and monitoring for nausea as well in those patients. So what about combining our atogepant, for example, with our gepant, like rimegepant or ubrogepant? A phase 1b open label of atogepant 60 milligrams for prevention and ubrogepant 100 milligrams Q3 days. About 31 patients were enrolled, 26 were completed, and we found that there was a 19% increase in the ubrogepant AUC plasma concentration and a 26% increase in ubro max plasma concentration. I mean, what does it mean? We see that the concentration goes up, but clinically it doesn't end up being so meaningful. It's just still monitoring for that nausea and constipation specifically, asking the patient if they're having any additional fatigue. So we prescribed Sadia a gepant, but she has questions. Which medication is stronger, the triptan or the gepant? And can I take them together? I still give patients a toolbox in most cases so that they can get rid of that migraine attack as soon as possible on day one. So I'm giving them a plan A, B, C, sometimes a plan D for that day one to break the attack so they're not going into status migrainosis. But here are some 2-hour pain freedom rates with therapeutic gains. I have to say here, when triptans were being studied, the primary endpoint was pain relief. And when gepants were studied for acute treatment, pain freedom was the primary endpoint. So it's really hard to compare apples and oranges, but this study started to do so. So you can see here the therapeutic gain between rizatriptan 10 milligrams, the triptan specifically, as compared to NSAIDs and our rimegepant or ubrogepant. And then combining acute treatment, we found, just in summary, that combining a triptan and a gepant together was not really effective than using just one of the therapies. You know, it's interesting because we know that NSAIDs, for example, we have that CNS absorption of the medication, and so we have studies looking at the combination of triptans and NSAIDs together, and that might be a helpful combination, but the same is not true for gepants and triptans specifically. But that doesn't mean I still add both in many times to that plan A, B, C for patients as backup. This was the CAMEO study, which specifically looked at chronic migraine, the chronic migraine population through survey studies across the United States. And these were the most common reasons that patients discontinued their acute treatment. In this particular study, they were prescription acute treatments, and the vast majority were triptans and opioids. And they graded the discontinuation with the level of disability that the patients had using the MIDAS quality of life, the MIDAS disability assessment. The lighter colors are people who tend to have more disability, and the darker brown here, the darker colors are people who had less disability. And in the vast majority of people, they're saying that they had lack of efficacy, safety or tolerability, cost, the same things that we see in our practices for triptan or discontinuation. I don't see many opioid users in my practice anymore, which is good for the purposes of what we do. And here are some risk factors for migraine disease progression. The main ones end up being, for folks who are going from episodic migraine to chronic migraine, head injury, mental health comorbidities. Certainly, I see a lot of obstructive sleep apnea and sleep disturbances. and metabolic diseases and coexisting chronic pain conditions. I cannot show this slide without telling you the wave of people I've had in my practice who are on tirzepatide, right? GLP, GIP medications, right? There's been a wave of these weight loss medications. What I'm seeing is, interestingly, when those patients are on those medications, the tirzepatide just as an example, and on their migraine preventive therapy, I'm seeing a bigger drop certainly over time in their migraine frequency. I think this is something that we certainly have to study in the neurology and headache world because everybody's on it. Even my patients who are normal weight are on it. And when I ask them, why are you on tirzepatide? They just say, I want to lose my last 5 to 10 pounds. And then they come in unrecognizable. But we have to be aware of what's going on. We need to know more about this interaction because it's doing something to the headache frequency. It's dropping it for sure in my practice. Is that what other people are seeing? How many people have seen a reduction in headache frequency when their patients are on that weight loss medication and migraine prevention? Happier. Ooh.
Or exercising.
Or they're exercising, that's a factor. Maybe they got rid of their obstructive sleep apnea, right? We know that's a new indication for that weight loss group of medications. So prior auth 1 here, and we added fremanezumab, 225 milligrams monthly, and she reported a 15-day reduction in her monthly migraine frequency, so daily to 15 days a month. And we have to tell her no more NSAIDs because she's having gastritis. Thank you.
Okay, so I just want to make one other point about the last case. I think if your patients aren't getting better, the vast majority of primary headache disorders, I think, can be pushed around. I think we have lots of good treatments, and most people improve. And if you're not seeing improvement as you expected, instead of layering on that second and third treatment, take a step back. As I say to my residents, stay curious and think, okay, is there a secondary headache syndrome on top of their primary headache disorder that is getting in our way? So always stay curious.